So the lymph system has been something that's been studied since ancient Greek days. The name cancer comes from the Latin, which describes crab, which is that they identified very early on that cancer was something that had tentacles and something that grew along tentacle lines. And a Dr. Sappi, who studied lymphatics in the late 1800s, described lymphatic channels and described this relatively orderly drainage of skin along these lymphatic channels, and he tried to use that to predict where cancers would drain to. We've tried to take advantage of those things as we've evolved over time. And in the 1990s, Dr. Don Morton and his group at John Wayne Cancer Institute identified that if they injected material, whether it's radioactive material or blue dye, in the skin around the area or the lesion of interest, that it will go along the lymphatics to the area or the lymph node that's draining that lymph node. And they call that the sentinel lymph node, the first lymph node. Now I'm going to digress just a little bit from melanoma and go to breast cancer. So there's different ways of thinking about tumor spread. And in the late 1800s, early 1900s, Dr. Holtzman, who was a breast surgeon or a surgical oncologist who focused in breast surgery, identified or thought that he came out with the hypothesis that the spread of tumor cells is in a contingent manner, meaning that there was a stepwise progression of cancer. Cancer goes from tumor to lymph node to elsewhere. And the theory that if he can get ahead of the tumor spread in that stepwise progression, he can cure cancers. So he came up with the radical mastectomy and then the extended radical mastectomy. And he thought if he can surgically remove more and more and more, maybe he'll have a higher rate of cancer cure. So he was doing horrific operations on people, but at the time, it was thought that he was giving them the best chance at cure from their cancer. We've had the pleasure of having Bernie Fisher here at the University of Pittsburgh, and he had headed up the NSABP trials in breast cancer, looking at whether or not there really is a benefit to doing bigger surgeries in cancer cure. So he described that there is no orderly pattern of tumor cell dissemination, and that when a tumor sends out or spreads via the lymphatics, that's just an indicator that it has the ability to spread the cells elsewhere, not necessarily in a stepwise progression, but it's just an indicator that that tumor itself has the ability to spread. And he has proved this in breast cancer, and we are using that data to encourage us in melanoma to learn more about the spread of melanoma. So out of John Wayne Cancer Institute and Don Morton's group, after he introduced the sentinel lymph node biopsy in 1990, he then initiated a trial, a multi-center international trial, starting in 1994, looking at patients with melanoma and doing a sentinel, and either doing sentinel lymph node biopsy followed by completion lymph node dissection if the lymph node was positive, the sentinel lymph node was positive, versus no sentinel lymph node biopsy, you just had observation. They accrued 2,001 patients. 60% of the patients went down the sentinel lymph node route, 40% of the patients went down the observation route alone. They monitored the patients post-operatively or post-diagnosis, and it was clinical exam, blood tests, and chest x-ray every 3 months for 2 years, then every 4 months for 3 years, then every 6 months for years 4 and 5, and then yearly from 6 to 10, which is very similar to the way that we continue to follow people today. And what they identified in looking at the entire group, there was no difference in disease-free survival or melanoma-specific survival in the entire group of 2,000 patients. What they did identify was that the sentinel lymph node, when it was positive, was the strongest prognostic indicator of whether or not a tumor was going to have aggressive biology. So this justified that the sentinel lymph node biopsy is incredibly important. They then went on to breaking out the groups and doing subset analysis within this group of patients. And what they identified was that in the intermediate thickness group, 1.2 millimeters to 3.5 millimeters in depth, if you had a sentinel lymph node biopsy positive tumor that went on to completion lymph node dissection versus no sentinel lymph node biopsy, but then you went on to develop axillary draining lymph node positivity, that there was a difference in the 5-year melanoma-specific survival in that patient population. So from this paper, the conclusion was that sentinel lymph node biopsy is the single most important prognostic indicator in melanoma, and that in intermediate thickness melanomas, that a sentinel lymph node biopsy followed by a completion lymph node dissection, if the sentinel lymph node biopsy was positive, could possibly improve disease-free survival and melanoma-specific survival. So this encouraged us to maintain our way that we were treating patients, which was completion lymph node dissections. So we continued to do that for the next 12 years. Now the criticism of the paper was that was not the final endpoint of the paper. They never designed that paper or that study to look at that question. And that the number of patients that were in that subset analysis was not necessarily powered enough to really prove that point. And this group identified that and took that criticism and then started the next multi-institutional trial in 2004 looking at completion dissection or observation in patients that had sentinel lymph node positive diagnosis. So they went on for their wide local excision with their sentinel lymph node. Their sentinel lymph node was positive, and then they were randomized to either completion lymph node dissection or no completion lymph node dissection. And I'm sorry, I also just want to identify the published dates for many of these papers. So this paper was just published June 2017, so less than a year ago. So the eligibility criteria was just that they had an intermediate thickness melanoma with a sentinel lymph node that was positive. The primary endpoint was melanoma-specific survival, but they also looked at secondary endpoints: overall survival, disease-free survival, survival without recurrence, distant metastases-free survival, and extent of nodal involvement. So when they looked at the patient characteristics, there was no difference in the patient characteristics between the two groups. I just want to identify 3 particular characteristics. One, the median depth of the melanoma was 2.1 millimeters in depth, so well within the intermediate thickness melanoma. That there was no difference in the size of the lymph node metastases. Some people have talked about microscopic versus macroscopic lymph node metastases. There was no difference between the groups. And also the last point, which I'm going to get to later, but that a very, very small portion of these patients, 6% of these patients, actually received adjuvant therapy or preventative therapy after the sentinel lymph node biopsy. And what they identified at 3 years follow-up was that there was no difference in melanoma-specific survival. You can see that there's no divergence of the 2 lines. And when they went to look at each of the subgroup analyses, all the different subgroups, thickness of melanoma, number of lymph nodes, that there was no difference in any of the subgroups. So that for anybody who's presenting with a sentinel lymph node positive disease, that there's no subgroup that's going to benefit in this paper from a completion lymph node dissection versus no completion lymph node dissection and close observation. But again, as Melissa talked about earlier, the observation, people have to follow with their observation, which is every 3 months for 2 years, every 6 months for 2 years, and then yearly thereafter, getting the ultrasounds, looking at that lymph node basin, and if tumor starts to grow in that lymph node basin, then we take them for completion lymph node dissection, and only if they present with disease. And within that group of population, that whole entire population, that was about 20% of patients that had sentinel lymph node positive disease, did not get completion lymph node dissections, and then later presented with lymph nodes. So 80% of those patients we already saved from having an axillary lymph node dissection. So there was also no difference in distance metastases-free survival. There was the question that, does a metastases metastasize? So if we left that lymph node in, or the possibility in that 20% of patients that we left that lymph node disease in and allowed it to grow, did that have a chance to then spread, that stepwise progression? And there was no difference in distance disease-free survival as well. Now there was a dramatic difference or a significant difference in the adverse events when somebody had a completion lymph node dissection versus no completion lymph node dissection. They had a lymphedema rate of 25% in the patients that went on to get their completion lymphadenectomy. So it is not an insignificant surgery to go on to get your completion lymph node dissection. So the conclusions of that paper was immediate completion lymph node dissection does not increase melanoma-specific survival. Immediate completion lymph node dissection increases rate of regional disease control and provide prognostic information, but again, it does not change overall or melanoma-specific survival. Now I enter into an area that's not my specialty, but by association, into the medical oncology arm of things and what Dr. Kirkwood was talking about. I won't get into the nitty-gritty of these papers other than just saying that the head author on this was Dr. Kirkwood himself, but that in patients with BRAF mutated melanomas, and again, this was published in November 2017, that there is a 50% decrease in the likelihood of recurrence of your melanoma if you had a sentinel lymph node positive melanoma and you had adjuvant therapy. So if the likelihood of you developing nodal disease is only 20% after a sentinel lymph node biopsy, and then Dr. Kirkwood treats you with the appropriate therapy, and that decreases it by 50%. So now we're talking an even smaller portion of patients that will present with axillary or inguinal disease. So even a less smaller group of patients that are going to go on to need their dissections. Now the one caveat is every patient that was enrolled in this had a completion lymph node dissection. So, but it's hard to believe that therapy for adjuvant therapy that works elsewhere is not going to work in the lymph nodes as well. So that is in the BRAF mutated arm. And in patients that are not BRAF mutated, they'll get pembrolizumab. And again, they looked at this population and there's a 43% decrease in metastases in patients that get adjuvant pembro. So again, in this group of patients, there will be even less patients that will present with regional disease that will need to go on for surgery. So conclusions is sentinel lymph node biopsy is the single most important prognostic tool we have to show us the biology of the tumor. Completion lymph node dissections can control regional lymphatic disease, but does not change overall survival. Conservative management of axillary disease should be under a program of close observation and serial ultrasounds every 4 months for 2 years, every 6 months for year 3, and annually from years 3 to 5. With continued improvement in targeted therapies and immunotherapies, we can further decrease recurrence rates, both local, regional, and distant, and potentially alleviate the need for further surgery. So it's nice to finally have data to show that we can do less radical surgery with the same outcomes. Thank you very much.